This is part 2 of the ESGAR update. Last episode was primary staging. This one is restaging after neoadjuvant treatment. The headline restaging has been rebuilt around organ preservation. The question used to be, what stage is it now? Now it's, is this a complete responder who can keep their rectum? That reframe drives almost everything else. Same panel and process as part 1. 26 radiologists, 18 countries, the same consensus method. 49 of the items were about restaging and 48 of those reached consensus. That's 98%. Only one item didn't make it and it sat at 73%. That was whether to use the same response criteria for solid and mucinous tumors. I'll come back to that. The reframe is the thing to hold on to. Your job at restaging is to sort patients into 3 buckets tied to what happens next. ESGAR now wants an overall response classification in every restaging report. 3 categories: complete or near complete response, homogeneous fibrosis, no real diffusion restriction. These are your watch and wait candidates. Minor residual tumor, some intermediate signal in the fibrosis, maybe focal restriction. These might go to local treatment. Major residual tumor, a persistent solid mass with diffusion restriction. These need radical surgery. Say which bucket in the conclusion. That's what the multidisciplinary team acts on. T2 alone reliably picks out the major residual tumors who need surgery, but for the complete responders, you have to combine T2, DWI, and endoscopy. No single sequence calls it. This changes how you handle the T category. In a suspected complete or near complete response, don't report a detailed YCT. It's unreliable and it has no clinical value. A range like YCT03 just risks knocking someone out of organ preservation for no reason. This is a real change from 2018, which still asked for a YCT in every case. One thing to flag, this is a European panel. In every US institution I've worked in, we don't restage the primary tumor with a YCT at all, we just report the response. We do restage nodes. If that's your practice, the panel's broader point still lands. Don't put a confident T category on fibrosis. When there is residual tumor, report YCT as an estimate, the maximum, and your measurements should encompass the whole fibrotic remnant of the tumor bed. The tumor is scattered inside that fibrosis and the surgeon takes all of it. DWI is now mandatory for response assessment. It's what separates real residual tumor from complete response. But use it for one job in T staging, YCT 0 versus YCT positive. Don't grade the T category of DWI. Read it together with the ADC map and look at the shape of the signal. That's what filters T2 shine through, susceptibility artifact, and inflammatory signal in ulcerated mucosa. And remember, the MRI response lags the histologic response. Residual signal can persist when there's little or no viable tumor left. So for a borderline near complete response, a second look at short interval is reasonable. On grading systems, Mr. TRG gives you a rough good versus poor read, but it can't reliably call a complete response, so it's not in the template. The fascia and vessels get treatment-specific rules. If a fat plane reappears between the tumor and the MRF after treatment, call the margin cleared, YCMRF negative. If you see only stranding into the fascia, that's equivocal, not necessarily involvement. The 1 mm cutoff is the same as primary staging, and it still counts if residual tumor, YCMVI, or a persistent irregular node sits within 1 mm. MVI uses the same grade 3 to 4 cutoff for positive. One useful shift, DWI now adds value for both YCMRF and YCMVI after treatment. The old guideline said DWI wasn't accurate for these. The evidence moved. Nodes after treatment. The mesorectal cutoff goes back to 5 mm short axis, with eyes open about its limits. But the real message is don't be rigid. Read the nodes in correlation with how the tumor responded. When the lumen shows a complete response, the nodes almost always followed. Only about 7% of complete luminal responders have residual nodal disease, and isolated nodal regrowth during watch and wait is rare, about 3 to 6% of all local regrowths, so the test of time approach is reasonable. So for a borderline node in someone heading for watch and wait, use the test of time, re-image in 6 to 12 weeks. If it stays small or shrinks, that's reassuring. Report YCN 0, possibly YCN positive or YCN positive with your confidence, and let the team decide. Lateral nodes are different from primary staging. There's no reliable size threshold for restaging. Just describe how they changed and correlate with everything else. And the one mucinous tumor caveat I promised earlier, MRI, including DWI, can't tell acellular mucin from mucin that still contains viable cells. The flip side, some solid tumors develop mucinous degeneration after chemoradiation, which is a cellular and not a worse tumor. The panel kept the same response framework for mucinous lesions, but flagged the lower accuracy. That's the item that landed at 73%. So what changed? Restaging is now organized around 3 response groups tied to treatment, stop forcing a YCT in complete responders, and a reminder that US practice is often more aggressive about that already. We typically don't restage the primary at all. DWI is mandatory and it now helps with MRF and MVI too, but read it with the ADC map and respect that MRI lags histology. Nodes get read against the tumor response with a 5mm cutoff and a test of time option, and no threshold for lateral nodes. And the mucinous criteria are inherited, not validated. Hold them lightly. The bigger picture is that complete response is becoming the goal, not an accident. As organ preservation spreads, more of your Restaging reads are really one question asked under uncertainty: can this patient safely keep their rectum? Stating that judgment clearly with your confidence attached is the job. That kind of reasoning out loud is exactly what I wanted Rad Reason to support. That closes the 2-part S-Care update. Primary staging was the last episode. Restaging is this one. Links to both papers in the description. I'm Melina Pektasidis, and this is Rad Brief.